On December 8, 1995, the Healthcare Financing Administration issued its final rule regarding Medicare payment for services of teaching physicians. At the heart of the rule is a clarification of existing Medicare payment policy related to the physical presence of teaching physicians. This rule will go into effect on July 1, 1996. To help its constituents prepare, the Association of American Medical Colleges sponsored a special conference on the Medicare rule. We believe the following excerpts will provide clinical faculty, residents, and billing staff with important information and clarification on the new rule and its implementation.
I would like to begin by first thanking the AAMC, and in particular Bob Dickler and Robert D'Antuno for sponsoring this conference this morning. I think this is a terrific idea, having this forum, and I'd like to thank all of you for coming. Our goal in publishing the new teaching physician policies is, broadly speaking, to bring some clarity and consistency to an area that historically has lacked both. And I think one of the most significant aspects of the regulation was a process piece of it, and that was delaying the effective date until July 1st of this year to provide opportunity to have sessions like this and like the one we had last week with a small work group, and so that we could consult with teaching institutions and many in the physician community as we develop the detailed manual instructions that will be used to implement this change. I'd like to emphasize that the thoughts that we are expressing today reflect only our current thinking on this, and if they were final, they would already be published and we would be implementing them. And the purpose for having them presented today is to begin, or rather to continue the dialogue that we've had on these changes. So it's our current thinking, but it's not our final thinking. Everyone is probably familiar with IL 372, developed in 1969 as a means of documenting the involvement of the teaching physicians in patient care services that are furnished in teaching hospitals. This policy has been controversial from the beginning, confusing, and not always applied consistently, as you all know. There was a Part A intermediary letter, 70-7, and a Part B letter, 70-2, that attempted to clarify through a series of questions and answers the physician presence that was required for outpatient services, that the physician would either personally perform the service or function as the attending and be present while the service is furnished. This instruction was put forth in the context of a Medicare payment system for physician services that was based on reasonable charges, that had wide variations among carriers in payment, coverage, and billing practices. In short, it was the concept of the Medicare program in the early years of being based on local market conditions, local prevailing charges, local medical practice. Medicare's evolved substantially since the early days of the program, and one extremely significant advance in that regard is implementation of the physician fee schedule in 1992, which moves us towards increasing standardization of payments and policies for all physician services and among all carrier areas. And I think the changes that we promulgated in the physician rule last year with respect to teaching physicians are best seen in that context. This chart summarizes the major changes that were included in that rule. We eliminated the attending physician requirement to reflect that care is being provided by groups rather than individual practitioners. This provides flexibility in providing care to beneficiaries. It avoids operating at cross purposes with managed care plans, which rely on a team approach to care. And it removes a burdensome requirement to verify the medical records, that there was continuity of care by the attending physician. That documentation burden is removed by eliminating the attending requirement. We also clarify the physician presence requirement, and we will be saying a lot more about that in the course of the morning, getting more and more specific about how that might apply for different types of service, surgical services, E&M services, what documentation would be required, and so on. I just wanted to establish the overall context for Medicare support for teaching-related activity. On the Part A side, on the left-hand side of that chart, you see that through the fiscal intermediary, we make Part A payments for the resident's salary, also for supervisory physician costs. On the right side, you'll see that we make through the carrier Part B payments based on the physician fee schedule for services, for patient care services that are actually provided by the teaching physician. And so we have two different ways that we support both teaching activities and patient care services that are related to those teaching activities. The most recent funding levels that I have for those programs, for direct medical education, we paid $1.9 billion, and for indirect graduate medical education, which is included in the prospective payment system payment, we paid $4.9 billion, and for direct billing under Part B to teaching physicians for attending services, I do not have a figure. The RBRVS, Resource-Based Relative Value System, provides national payment amounts and national uniform definitions of codes. And again, I think over the last several years, as a result of a very good working relationship with the AMA and the CPT committee, there have been continual improvements each year in the descriptive in the descriptors that go with the codes and in the specificity of those codes with appropriate revisions to the codes. We make payments based on relative value units that describe the time intensity of physician work needed to produce the service, and other payments for practice expense and malpractice. And again, we've been fortunate to have a very good working relationship with the physician community, both through comments and relationships with individual specialty societies, as well as the extensive amount of surveying and work that's done through the RUC process, Relative Value Update Committee process. And I guess the last point I'd like to make on this slide is that, as you all know, the global fees for surgery include preoperative, intraoperative, and postoperative procedure work. With respect to our teaching physician policy, clearly the basic requirement is that the physician must be present at some time when the service is performed in order for the service to be billed under the Medicare program as a physician service and for Medicare to make a payment. The general rule, as provided in the regulation text published last year, if a resident participates in a service furnished in a teaching setting, the physician fee schedule payment is made only if the physician is present during the key portion of any service or procedure for which payment is sought. And the discussions that we will have throughout the morning will attempt to define more specifically what we mean by this physician requirement, physician presence requirement, what is the key portion of the service, and what that is in the case of surgery services, what that is in the case of E&M services. This time I'll turn it over to Terry Kay.
Okay, I'd like to continue with more of the basic policy, and more specifically as it applies to surgery. As indicated on this slide, the physical presence rule means that the teaching physician must be present during all critical portions of the procedure. It must be immediately available during the entire service. During this discussion, I'll provide more detail about what we really mean by this. As we start to get into more of the detail, the questions are, well, how do we define key portion and what does immediate availability mean? And as Tom indicated, we can only give some tentative answers here because we still are in a consultation mode working with interested groups.
Since the AAMC's February 12th conference, the Healthcare Financing Administration has revised its interpretation of these provisions regarding surgical procedures. While still subject to change, the current interpretation would allow the teaching physician to self-define the key portions of major surgical procedures. The teaching physician must be immediately available to return to the procedure after completion of the key portions. This interpretation allows teaching physicians to begin non-critical portions of a second concurrent procedure. Further instructions on these provisions will be published by June 1st.
Before I move on to this slide, I just want to make a couple comments about other issues in surgery. For minor surgery, the policy would still basically be the same as for major surgery. However, in this case, the key portion of the minor surgery would, in many cases, be the entire procedure, because there may not be a separate opening and closing for a minor skin procedure, for example. And in this case, the physician, the teaching physician, would need to be present during the entire minor surgical procedure in order to bill Part B. And the other issue in surgery deals with policies for endoscopies. The teaching physician during scopies would need to be present during the entire viewing of the endoscopy. And the definition of the viewing of the scopy would depend on the purpose of the procedure. And so an example would be for a colonoscopy that basically the viewing part of the colonoscopy would be whatever the physician normally looks at when in fact they do a colonoscopy. I'd like to just review a few common questions that have come up, such as on these slides. I won't read all of these, but if you had a chance to look at them, basically they deal with what other work that the teaching physician can be doing during the non-critical portions of major surgery. During non-critical parts of major surgery, we believe it would be okay for the surgeon to be doing certain other activities, such as reviewing records or preparing for the next procedure. We believe these types of activities would allow the surgeon to return to the patient if necessary. Again, it's tentative, but we're considering defining immediate availability as meaning that the surgeon is in the operating suite. Can the teaching physician begin another procedure if another teaching physician were close at hand? And again, it's tentative, but we believe this would be okay, that the teaching physician could do another procedure as long as some other teaching physician is immediately available. But I would note, of course, that we would not be paying extra for that second teaching physician. The final common question that we'll address now is this one, that can a surgeon bill for the post-op visits if he or she was not present for the original surgery? And the example that's come up on this is perhaps a resident would set a fracture in the middle of the night without the teaching physician being present. Again, we agree it would be okay for the surgeon to bill for these follow-up visits if the surgeon were present during those follow-up visits. But we're considering having a rule that the total billings for these post-op visits could not exceed the post-op portion of the global fee. The last issue that I wanted to discuss at this time is just to briefly mention radiology and diagnostic tests. This slide shows the basic policy for radiology, and we believe it's reasonably straightforward, and we think you agree. We have not had a lot of questions raised, at least so far. And I think the policy can be illustrated most easily with an example. That, for example, for a chest X-ray, in this case, the teaching physician radiologist could only bill for the X-ray interpretation if he or she personally reviewed the X-ray and then wrote a report, or reviewed the interpretation and report submitted by the resident. Okay, now I'm going to turn it over to Bart McCann, who will go over the evaluation and management criteria.
Good morning. I'd like to cover the evaluation and management services primarily, and at the end go over some of the exception, or explain a bit of the exceptions policy. Evaluation and management services, I'm sure you know by now, refer to visits and consultations and all those services that are now listed in CPT with more complicated codes than there used to be. E&M services represent about 35% of our payments to physicians under Part B. So we're well over $10 billion in payment for this relatively small handful of codes. As Tom mentioned, under the RBRVS, we're required to develop resource payments for those services that include payment for physician work. As the fee schedule was about to be developed, we knew from the report that we had gotten from Dr. Shao at Harvard that the old visit codes that many of you may remember as minimal, brief, limited, intermediate, extended, and comprehensive were not going to work anymore because people didn't know what the words meant, and they were being used in quite different fashions all across the country. So as part of getting ready for RBRVS, new visit codes were developed, now called evaluation and management codes, developed with considerable input from all of the major specialty societies. I'm hopeful that you all who are seeing patients are now familiar with those codes, and if you're not, you're going to have to become familiar pretty quickly because they're going to be critical to the documentation requirements that we'll get into in a little bit. As I mentioned, the old codes just had a single word descriptor, brief. That was about it in the old CPT book. Now all of the codes have in their descriptor 7 elements. Those elements being the extent of history, examination, decision-making, coordination of care, the nature of the presenting problem, and the typical time it takes to provide that service. Now under this coding system, 3 of those elements are considered to be key for evaluation and management services. Those are extent of history and examination and the complexity of decision-making. So I'll be coming back to that again. We're going to be talking about history, exam, and decision-making. I want to restate what our basic policy is going to be. It's not just for E&M, but across the board. But I think it's important for you all to be sure you take this away when you leave today. That is, if a resident is participating in a service furnished in a teaching setting, Medicare Part B payment under the physician fee schedule may be made to a teaching physician. Let me pause here and define a teaching physician, which was in our regulation. That's a physician who involves residents in the care of his or her patients. I frequently run into people who think of this teaching physician role having to do with residents. It really is having to do with your patients. We're viewing the payments that we make to you for your patients. A teaching physician is one who involves a resident in the care of his or her patient. So please keep that in mind. So payments can only be made to a teaching physician under Part B if the physician is present during the key portion of the service provided by the resident and for which payment to the teaching physician is sought. Now the other side of this policy, a service furnished by a resident in a teaching setting without the presence of the teaching physician is not covered as a physician service, and Medicare Part B payment cannot be made. So if you're not there when the resident sees the patient, we aren't going to be making payment to you under Part B. Now we have been working, as Mr. Alt mentioned, with a work group and have been trying to get a little clearer on what we mean by key portion and what kind of documentation guidelines we're going to have. We have been working so frequently on them that in fact the slide package that was sent down here on Friday didn't include some of the things that I'm about to cover for you. So let me go a little bit slower here because I don't have a slide on that. There are major parts of documentation that we're going to get into, and I've mentioned to Stan Weintraub, who's going to be talking about documentation. I'm going to steal a little bit of his presentation here because I think it's important for you to understand what it is we're looking for, what our expectations are of the teaching physicians. There are two ways that we're going to be looking for you to document your presence and your participation. All right, there are two ways this can happen. One is a notation that you were present during the key portion of the resident's history and examination of the patient, and you discussed the decision-making with the resident during or immediately after the patient encounter. Okay, so you're there in the room when the resident takes the history and does the exam during those key portions of that, and you discuss the medical decision-making with the resident. Now, for some of you who may not have gotten quite up to speed yet on the E&M services, the decision-making refers to the number of possible diagnoses and treatment options, the amount and complexity of data that needs to be reviewed, and the risk of complications and comorbidities associated with a patient's condition, and any treatment options that you're considering. So those are the things. I think these, I'm not really describing something that you're not familiar with. This is what you already are talking to the resident about, which is what is this patient's problem and what are we going to do? All right, so one way is you're in the room with the resident and you discuss the decision-making with them afterwards. The next way is that you personally obtain a key portion of the history and or perform a key portion of the examination. And this is you yourself. The resident may not be there, but you yourself got the key portion of the history, or I should say the key portion of the exam. And again, as in the last one, discuss the medical decision-making with the resident before the end of the patient encounter. Now, I've said those a little differently, and a better way than before the end would be during or immediately after the patient encounter. We don't mean that you have to discuss this decision-making in the presence of the patient, but we want it to take place in close temporal proximity to that patient's visit. I think in an outpatient setting, it would pretty much be before the patient left the center. You've talked to the resident about what the treatment plan, what the diagnosis is, et cetera. All right, so that's how you're going to document your presence and participation. You have a little notation. I was there and I discussed it with a resident, or I did it and discussed it with a resident. Now we get into this question about the key portion. Let me give you the tentative definition of what we're thinking about at the moment for the key portion of E&M. The key portion of the service is defined as the elements of history, examination, and decision-making that in the judgment of the teaching physician best summarize relevant history and examination, assessment, clinical impression or diagnosis, and plan for care. Now, you can cover those things. We're leaving it to the discretion, to the judgment of the teaching physician as to what those key elements are. In other words, you're not going to have to write out this big, extensive family history if the family history in the particular case you're dealing with is more or less not relevant to the case. But we expect you to identify what is the key part of the history. That may be one word, asthma in status asthmaticus. That may be very descriptive of what you believe the key element of history to be. Let me get to the issue of the level of service, which we have up here, because it talks about, on the slide, the portion of the service that determines the level of service billed. In addition to revising the codes back for the 92 CPT book, the AMA and HCFA and the specialty societies have put considerable effort into documentation guidelines for evaluation and management services. I'm curious, since we have such a big audience, if I could ask those of you who are here who may be familiar with this little pamphlet that talks about documentation guidelines to raise your hands. Anybody have? All right, there's some of you are. Let me say that it's going to be, by the time July comes around, it's going to be important for you all to understand what's in that, because this is the documentation guidelines that we've worked out, as I said, with the AMA and the specialty societies. It's kind of the minimum amount of information that needs to be in the medical record. It explains what we mean by history, how much you have to have down about review of systems, what's a past history, how much examination has to be documented for, say, a detailed examination versus comprehensive examination. That document is used both by practicing physicians and by our carrier reviewers in the event that someone's records are to be audited to check on the level of service. They will be using those documentation guidelines to determine whether the information in the chart supports the level of service billed. So it will be important for you to get a hold of that. Now, assuming you've documented that, this level of service business, there are 2 points that I want to make here that are important. One is this documentation that I just talked about. We've got pretty clear guidelines now in place for you to identify what's a comprehensive exam and comprehensive history and what constitutes, let's say, moderate complexity of decision making. We want you to follow that. The record should follow those guidelines. That's one part. But there's another part of this related to the teaching physicians, and that is that we're going to be looking to you, the teaching physicians, to identify whether or not those services that were documented by the resident were in fact consistent with the patient's clinical needs. So a patient who comes in, let's say, to the outpatient department and has an upper respiratory infection and is seeing a resident for the first time, it's not a new patient, let's say this, but this resident is seeing them, they're new to the residency program, and they write out this very extensive history, physical and decision making, when that patient really needed just a lower level service. We'll be looking to you, the teaching physicians, to submit a bill to us based on what the patient's needs were. That was sort of probably a rule of thumb is, if you were to see this patient, what level of service would you have billed? Now, this may come across as we're putting an extra burden on you all, when in fact we really aren't. For the practicing physicians, when our carriers are reviewing evaluation and management services for the appropriateness of the level of service, they're looking at two things in that case also. One is whether or not the guidelines have been followed, and that is the level of service that's billed is supported by documentation in the record. But they also take into account the medical necessity, so that a patient that came to a long-standing GP, I'm talking about outside of any teaching program, who gets a level 5 for a little bit of eczema, and the carrier reviewing that decides that wasn't medically necessary, even though the record might have a nice computer-generated complete history and physical, our carriers wouldn't recognize that as a level 5 service. So we want you to look at both the documentation using the guidelines and take into account what the patient's needs were before you submit a claim to us. Now here's a common question. What's the payment policy when the resident and teaching physician see the beneficiary at different times, that is, separately on the same day? I think I explained that when I was first discussing the basic policy, but let me go over it again because it keeps coming up, and it keeps coming up. In order for us to make payment to you for the care of your patient when you involve the resident, either you're going to be there while the resident's doing it, or you're going to do it yourself in the presence of the resident. This situation here is when you're by yourself. The resident is not involved. So the level of service then that you're going to bill for us, that you should bill us for, is what you yourself do, not what the resident did. So if the resident sees the patient, let's take a hospital patient, sees them in the morning, and you come around later in the day for the first time and see that patient by yourself, what you document in the record and what should be the basis of your submission of a claim to us should be what you yourself do. Now, I'll give you, before you get too anxious about this, you should know that the documentation guidelines allow, you don't have to write out everything in the history that the patient has done, that the resident has done, or you yourself have obtained, if it's already in the record. The documentation guidelines already allow that you don't have to repeat things that have already been obtained by someone else. You just have to have a notation that it's there. So if your note is following the other residents, it's pretty clear what, say, the history would be. One of the things that we're discussing with the members of this work group that met earlier last week is which parts of the resident's note can you cite? Our feeling at the moment is that it would be reasonable, since the documentation guidelines already allow for it, for you to cite elements of the resident's history, but that the examination that you document needs to be your own, and the level of service based on your own personal examination of the patient. All right, questions come up about psychiatry. Can a teaching physician review a tape of the session after the service is over, or must it be concurrent review? Our position on this is that you can't review a tape. It has to be happening at the time that it occurs. This is somewhat analogous to a review of a medical records and wouldn't constitute a service payable separately under the fee schedule. This may be a little tough to read, but I'm glad you all have, most of you have copies of these. This is a question about, for time-based codes like psychotherapy. Psychotherapy has codes that say individual medical psychotherapy by a physician, and there are some other words that go in there, and then it'll have the time period, 20 to 30 minutes. There's another code for 45 to 50 and one for 75 to 80. Must the physician be physically present or watching by video camera for the entire duration, a majority of the time, or some other standard? Our position on this is that you need to be present for the entire time because the service is based on the time spent with the patient. All right, in this case, when the second part that's up there is, should the teaching physician bill only for the time you spend observing, or can you take into account what it would be if you had provided the service yourself? What we're looking for is the time of the teaching physician observing the resident. Okay, let's go to the exception for certain evaluation and management services. In the spring, we call it spring, it always ends up being summer, spring notice of proposed rulemaking, we discussed the notion that there might be some family practice residencies that would that we might give special consideration to, special exceptions to under this teaching physician rule. In that notice, we also, in an invitation that we made for comments on that thought, asked for people to provide us comments on whether or not other primary care residencies might also qualify. I'm going to come back to this in a minute when we get to a later slide, but I want to underline primary care. We weren't saying pick some pieces if you're a residency and see if you can qualify. We're talking about primary care specialties. All right, here are some of the requirements for the exception. It must be furnished in an outpatient center or other ambulatory entity. The resident must have completed 6 months of training. No more than 4 residents may be directed at any one time. So you can't staff up a clinic with 10 residents and 1 teaching physician. Can't do any more than 4 at a time. And people question, well, why are you making it 4? How about 6, 7, 8? You know, we're looking, again, I'll come back to the definition that I had before of what a teaching physician is. This is a physician who involves residents in the care of his or her patients. We're just very uncomfortable thinking that 4 residents seeing patients and you having to talk with them, whether it could be done with 5 residents, 6, we just don't think it can. The next point is the patients must be an identifiable group who consider the center their source of continuing health care. And then another one that just didn't quite fit onto this slide is that we're talking about levels 1 to 3 of the office and outpatient hospital services. You might mark that down on the bottom of your slide. We're limiting it to office visits with either new or established patients at levels 1, 2, and 3. All right, the lowest levels you probably understand. The third level is one that requires what's called an expanded problem-focused history and an expanded problem-focused exam. The next levels 4 and 5 in the outpatient department get into detailed history exams and complete or comprehensive histories and exams. In those cases, we think the resident should involve the teaching physician to a greater degree, and we'd be back to the requirements that I had on the earliest slides. All right, some additional requirements. The teaching physician can't have other responsibility at this time. They can't be over in their office during this time seeing their own patients, or over in some other part of the building, maybe covering the emergency room. They have to be available, no other responsibilities. They're assuming management of the patient seen by the resident. I come back to, this is the teaching physician's patient. They're responsible to ensure that the services were appropriate. They have to review with the resident during or immediately after the visit the patient's care. So I'm going to come back and restate what I said before, whether you're outside the exception or in the exception, and whether you're with the resident when he examines the patient or you do the key portion yourself. In all of these situations, we're requiring that you discuss this case with the patient, with the resident, I'm sorry, before the patient leaves. And then finally, you have to document the extent of your participation in the service. Now, here's the question. It's probably I guess it's probably the most common that I've gotten so far myself personally about this when we've made this exception. And that is, the final rule states immediately available is not limited to family practice, and then it goes on to, people have asked, well, what about my clinic and cardiology and rheumatology and so on and so forth. People are picking out certain elements of our rules and saying, well, we're immediately available, or our residents have a continuity clinic. I think that what's happening is people are missing the main point of what we're trying to get here. We're talking about primary care specialties. You know, and what do the primary care specialties do? They're taking care of patients. They're teaching their residents about primary care so that their programs and the care that the residents are providing incorporates some very important principles of primary care. One is continuity, so that the same resident is seeing the patient over the long period of time of their residency. It's comprehensive. That means that they're ready to take care of all services. That means acute and chronic, preventive services, minor trauma. You know, you need to be prepared to provide a comprehensive scope. It's one way that I think of it is if something happened to the patient and they were sick and needed to be seen, where are they going to go? Well, in the family practice residencies and probably other primary care residencies that we're learning more about, you know, they would call their resident who they see as their physician. That means that in response to this last point here, is it care that's limited to a specific chronic problem? You know, I don't think you can do it. In fact, I know you can't do it. You won't be meeting our requirements. The service needs to be continuous, comprehensive. It needs to be accessible. It has to be coordinated. The residents are trained in these family practice residencies and other primary care residencies to coordinate the patient's care. That means they make the appropriate decision about keeping what they can handle and referring on those that they can't. It means that patients that are referred out, that information is actively sought out for incorporation into that patient's record, so that if someone picks up that record, they have a picture of the entire spectrum of that patient's care. And we started off with family practice in the spring. We're now open to other primary care, but we're not really considering cardiology and rheumatology and sports medicine because they are not primary care specialties.
The documentation requirements are summarized on the slide, and these are the ones, these specific requirements are essentially what our regulations text describe about documentation. But I think it's important to get into some general concepts of what documentation is, and generally where we are coming down right now on it, and how we are, what our going in presumptions are about documentation. Again, these are the assumptions that we're sort of talking about today, and as everyone has tried to emphasize, many of these issues are still on the table, and we are prepared certainly to deal with individual concerns, and some of the questions I think reflect that kind of approach to flexibility in dealing with these issues. I guess these questions sort of summarize some of the thoughts that go through people's minds when they start to deal with documentation, or what should I put down in the record. But in general, lack of or extensive documentation will not affect the payment on any single claim, except in certain cases where the carrier perhaps has identified a specific provider, or we're looking at a specific service, or something has come up that documentation is needed prior to the payment of the bill. But for virtually, I don't want to say all, certainly not all, but for the overwhelming majority of claims that are received by contractors, the claim is paid, and documentation is not an issue up front. But the nature of documentation comes into play when there is an audit or review of the medical records. And I don't want to take all the presentation, certainly from the afternoon session. I know it's on everyone's mind, and I know it is considered to be very serious. And we had received a briefing by the Inspector General in terms of, as was put to us, a large Eastern teaching hospital. And they, as part of their presentation, they cited for us some interesting facts. And again, I apologize to the people later who are coming, but that's too bad. As part of the audit review, someone had taken a look at the policy of the Department of Medicine at the University of Pennsylvania, or the large teaching hospital. And I'm not trying to be flip. This is a pretty serious issue. And it's interesting to note what the policy, the stated policy of the Department of Medicine was. The underlying, I'm quoting, the underlying maxim in professional billing, if it is not documented in the medical record, it cannot be billed. If it is not documented, it did not take place for billing purposes. And there were some allusions to the IL 372 policies in which this audit was based, or at least that's the standard that they used to view the medical records. And they said that counter signatures next to entries which fail to indicate that the attending physician was present are not in themselves evidence that a billable service was rendered. And that's, I guess, a statement of how the institution itself sort of tried to guide the documentation level in the medical records. Clearly, in a number of cases, those documentation standards were not met. When they went in and did their findings, they drew their conclusions about the review, they had some definitions of categories of findings. One definition for one category was, documentation in the medical chart does not support the level of service billed. That then became a potential claim under the False Claims Act, or potential fraudulent claim. Another violation finding, or statement of finding, documentation in the medical chart does not support that services were actually provided by a physician or under his direct and personal supervision. Resident notes do not indicate physician involvement. Another issue having to do with documentation violations. Documentation was not found in the medical record to support the service billed. So I think when you look at, and I'm sure you'll hear later this afternoon, about what documentation can do or cannot do, when I ask who cares and why it's necessary, I think today, more than maybe 6 months ago, it becomes clear why it's necessary. And I think that the physician, the hospital, and other parties closely related to the care of the patient should care about what was done to the patient and by whom. It seems that an adequate record of the treatment of the patient is essential for many reasons. And documenting that someone did something to base a claim against the federal government or even a private insurer is a key reason to have documentation. And demanding or requesting money when there was no service provided probably will be considered fraud. And if a service was performed and billed, it should be apparent from the medical, surgical, operative notes, or whatever else is being documented, that the service was performed and who did it. But what about the note itself? I'll move on to one of the question slides, because I think this slide is a key, not so much about the specific words on here, but is the general tone of a large number of questions that are coming to us about documentation in somewhat of a general way, in some cases a little more specifically. And the gist of the note, as you can see, seems to be, how short should the note be? How brief, how fewer words can I get away with? And will you endorse these brief notes? In our opinion, at least at the moment, I would sort of be shocked if it would change, but in our opinion, the note should be sufficient to indicate to a third party, the insurer and auditor, that a service was provided, the nature of the service, and who provided it. And it should be in sufficient detail to help the physician recall the event sometime later, if asked. And again, I apologize for the dealing with some of the results of the large Eastern Hospital issue, but when they had questionable notes and they asked physicians about them, they could not, in a number of cases, as we were told, recall what had happened. Their note was so brief and so difficult, or perhaps ambiguous, that they had a lot of difficulty recalling the event. Now, if you deal with 1,000 patients, certainly that's going to be an issue, but somewhere along the line, if particularly, if you're sort of very, very tangentially involved with a patient, you have to have something that sort of would set up that you knew what you were billing for and that you were there and you can recall in some way what was happening. And I'm just citing this as simply because of what we found that seems to be some type of a standard now for documenting medical records. And in that spirit, we don't plan to issue any specific language guidelines. And we essentially believe that experienced physicians in consultation with their colleagues, hospital medical records departments, and others will understand in general the principles of documenting the medical records. And if we could mandate sort of a general standard to use, it would be not to have as your goal the fewest amount of words as a note. Ambiguity, lack of clarity, and brevity could come back to haunt you. And keeping that, I guess, general principle in mind, the note also needs to be directed at the physician, at the specific requirements of this teaching physician rule. I think documentation as a general rule, at least as we see it, has a lot of these principles in it. But now we have to focus on what do you do as a teaching physician when a resident is involved in this care, and how do you meet our basic regulatory requirements. And you have to be able to note clearly that you were there. And I think that's a general principle, and if you were there, you should be saying was present. You also have to clearly indicate that you were there during the key portion of the service. And we have been very, we've been, I think, criticized internally a bit by our generosity, I think would be termed in the use of the word key, and that we are saying you're the only ones that know when the key part of the service occurs, and we're not going to tell you when it occurs except for some general guidelines, in certain cases maybe a little bit more specific, but you're going to have to tell somebody when the key portion was, and that should be in the medical record. And the note should also document the level of service. As Dr. McCann pointed out, that determines how much money you're asking for. And saying and using the AMA's medical record guidelines should be a focus or a way to establish the level of service, and the note and the documentation requirements to indicate that should be there. As I pointed out, the issues that and the questions, I call they'll have question marks after them, but what they're doing is prompting our the way we're going to approach the operating instructions and what are really on people's minds in terms of what should I put down, not specifically in words, but does this require documentation, and how should these documentation issues be addressed. So I think we'll take a look at some of the issues. And I think most of you have in your package our sort of tentative answers that we've come up with. These questions have to do with, this one specifically has to do with times. Should we note in the record what the times are? And I guess the general answer would be, if that's helpful for you and it was important to note, or was a policy of the hospital, I would note the times. I mean, clearly that's, but it's certainly not a documentation requirement. It may be helpful to do that for your purposes or for the purposes of the standards within the hospital or the standards within your group, but I'm not sure that we want to mandate you carry stopwatches around and put times down. This essentially goes to the some of the issues that hopefully will be dealt with when we get more closely and get farther along in our development of our billing and other clarifying instructions, because this moves to the issue of physicians' presence and how we want to better define it, or more careful, or more what detailed level of requirements we want to put on when the physician is present. And I think that whenever we come to that, the note should simply follow that. And documentation, again, is a matter of being clear and unambiguous about your being there. And you know, I don't know that we're going to challenge someone who says I was there. I mean, unless, of course, and you'll hear some of the vignettes later, that maybe that needs to be challenged in some cases. But as general documentation requirement, if you say you're there, and define that you were there during the key portion or whatever else you described, I think that should be sufficient for us. This is something that, that Dr. McCann had talked about. We're not quite sure whether this question was referring, this I guess is sort of an open issue still in terms of whether we are asking the teaching physician to personally write out a whole lot of stuff in duplication of what the resident has written. I'm not sure how we're going to come out on that. My proposal is, or my thinking is that we shouldn't be, that whose handwriting it is in terms of the note is not as important as a physician signing and putting down the key portion and physical presence and so forth, if he's simply going to duplicate what's already there. But I think we're still looking into that because some people have some concerns about that. Here's an issue, again, does the physician personally have to sign "I was there," or if the resident says, "I examined this patient with Dr. So-and-so, the attending," or the Dr. So-and-so, the attending was present at the time of my examination in history, whether that would be sufficient. Again, I'm not sure that our intention is to make onerous and useless documentation requirements. I think our intention is for the record to be clear about it and the physician to sign and agree that that was the case. But again, these, I just want to, since we're videotaping, I wanted to continue, just reiterate that these are issues on the table that we need to continue to work through. And I'm not sure what process the AAMC is going to work out with the group, but it may be, we don't necessarily want questions from everybody. If you want to formally write to us, we may want a funnel to sort of keep these things sort of organized when we get them. But our work group has this question on the table, and we're continuing to discuss it. And I think Dr. McCann had spoken about the second point on this. The issue of the exception and documentation is, I think you can almost use documentation and describe this in the same sentence with how are we going to administer the exception, and how is our claims system going to react to which claims fall under the exception or not. There's only a few levels of E&M codes that would even fall under the exception, and how do we deal with those kinds of things. And this is going to be, I think, probably one of our more difficult issues in terms of centers or residency programs are going to be asking for an exception, and how do we certify these things? How do we, do we do an attestation process, or do we, have a solicitation of who's qualified or think they're qualified, and then do some kind of certification as a result of that? And those issues are very difficult for us because they could, depending on which way we go, severely impact on the workload of our contractors. And that's something that we seriously have to be concerned about because of budget constraints. But certainly the types of centers and if sometimes you can handle these kinds of documentation issues one of two ways. You can assume that if you sign up as an exception, that you agree that you're not going to supervise more than, or at least have more than 4 residents, and all the other requirements become and when you submit a bill, you have made that agreement. It's sort of a tacit agreement, and that's the only condition of billing, and when you bill, then you say you've met those conditions. The other way to approach it is sort of, I guess that would be passively, and the other one is actively go out and take a look and see if you're actually doing that. And I'm not sure we're going to take that approach. I think the passive approach is certainly more appealing from a budget standpoint. Here's again, I guess the typical question is, how do we document we were there? I guess you say you were there. I was present during the viewing, and I reviewed the residents' conclusions, diagnosis or conclusions, and I agree or I agree with whatever you say. But if you say you were there, I think we would assume that you were there. and time in and time out. Again, if that helps you, that's fine. I don't know that that in and of itself provides anything for the medical record for us or for a reviewer, unless, of course, you think that that's a critical part of your physical presence there. Okay, and as we said, in the case of anesthesia, the documentation must indicate the presence of the teaching anesthesiologist. And the teaching anesthesiologist must be present during the key portion of the procedure and immediately available throughout the procedure. And documentation would certainly follow that general guideline in terms of presence. And in terms, I think if you understand our general feeling towards documentation, all of these questions can be certainly answered by just make sure that you say what you do and what you as a teaching physician have done, and that you participated in the interpretation, or you personally interpreted it, or and of course you reviewed the residents' conclusions or interpretations. But clearly, in terms of radiologic procedures, it would seem apparent that you have to look at the film. I think we had a question about that. I'm not sure that we put it in here, but it'd be hard. Someone actually asked us whether whether the teaching physician had to review the film. So we couldn't quite understand how they would review the interpretation if they didn't look at the film.
Well, I know you're all there thinking that the rules are vague. You heard Bob and Steve talk about them. Why did Penn settle? You know you're sitting there and you know you'll never pay. You'll fight based on the interpretation of the rules, especially since everyone does it. And then I'm sure there are a few of you out there who have maybe gotten over the shock of the Penn settlement, and you're sitting there and thinking, but for the grace of God, it could be me. If your institution becomes involved in an investigation, be it civil or a routine audit by the government, you're going to have to look individually at your own institution and make your own decision about whether it is something you're going to litigate under the False Claims Act with the various draconian penalties that are there, or if it's something that you're going to try to resolve. Just quickly to follow up on something Steve said, let me urge you, don't relax if your first contact by the government is not a subpoena. The government now is working on this healthcare fraud issue through numerous multi-departmental and multi-agency task forces. Because your first contact is a routine audit letter does not mean it's anything different than the subpoena or the various other modes of starting an action. So any contact by the government to review any of your billing practices should be something that you should take seriously. Whatever your opinion of why Penn resolved their issues the way they did, one fact remains, that every academic medical center would benefit by having a billing compliance program in place. It is essential in this environment which we are all living, where healthcare fraud is the #2 priority on the Justice Department's agenda. There are several reasons why effective compliance programs can be beneficial, even if the government is not at your doorstep. First of all, should they come, you look at the federal sentencing guidelines themselves. One of the things they look towards, and one of the things that they give you credit for, are having an effective compliance program in place to prevent and detect criminal conduct. Such a program can be helpful in a civil enforcement action as well, because it's indicative of an institutional desire to comply with billing and legal requirements. From a sheer business standpoint, an effective billing compliance program can help you organize your billing operations in a much more business-like and professional environment. At Penn, we read the handwriting on the wall, And in Philadelphia, it's very easy because we have one of the most aggressive assistant U.S. attorneys who's heading our civil division, who for 18 months prior to our involvement with the government had made it known that academic medical centers were next. The importance of having your own compliance program are manyfold. The government-designed programs are quite draconian, as many of you may have known if you've read the NME or the BARD compliance programs. If you get in a position where you may need to negotiate with the government, if you have your own program started or in place, you may be able to convince the government to use your own program as a basis. In the Penn situation, key portions of the clinical practices billing compliance program had been approved and implementation had just begun prior to the federal auditors arriving. That compliance program that had been approved prior to the government arriving became the basis of the government-approved compliance program that was part of our settlement, rather than the government coming in and placing one of their own draconian programs in place. Any compliance program you develop will have to be tailored to the particular institutional structure and the institutional needs of your particular organization. What I plan to do is tell you some of the details of the Penn program because it'll give you an idea of what type of compliance program can work in an academic environment, which is, as you know, very different than the for-profit environments where previous compliance programs have been put in place. The purpose of a compliance program for billing is to ensure the accuracy of all bills rendered for professional services provided to patients. As I indicated, in addition to assuring accuracy of regulatory requirements, it does assist in a more professional and business-like operation. Penn's plan has 4 major elements. The first element is centralization of billing functions. This is a process that was underway before the government arrived on our campus. However, we were able to use the government audit to push it forward in a much more rapid way. All business and financial functions in our faculty practice plan, including billing, will be operated under the direction of the Chief Financial Officer of CPUP. This is different than under the direction of 19 separate departments with 19 separate billing systems. As you can well imagine, a centralization in a situation such as Penn's, which may well be similar to many of your own, is needed because it is very difficult, if not almost impossible, to monitor 19 separate business functions. Another centralization function which we have already put in place is centralized inpatient chart abstraction. And this is where documentation that you've been hearing about all day is so key. Under an inpatient chart abstraction program, all coding for professional services is done by trained abstractors in a central office from the chart. If it isn't documented in the chart, these abstractors don't bill it. All coding is done from the chart. This system enhances the ability to establish and enforce compliance standards consistent with all billing requirements. It also helps encourage physicians to make sure they are accurately and completely documenting the chart, because if they don't, they're not going to get paid for their inpatient services. The second major element of the Penn plan, which is an element that must be in every compliance program, is monitoring and auditing procedures. As Steve mentioned, the monitoring and auditing procedures can be fraught with perils, but also are an essential part of every plan. When you develop your internal monitoring and auditing process, you must carefully evaluate the role of counsel and need to determine what counsel versus what your financial people or your auditors will do. If you get in a sticky situation, you may want to seek advice of counsel, and you may want to have counsel take over the auditing function in order to assist in providing the institution the appropriate advice. An internal monitoring process is essential. At CPUP, we've established, or will be shortly, an Office of Billing Compliance, which reports to the Chief Financial Officer. That office will regularly audit the effectiveness of compliance policies and procedures and make recommendations for changes to the CFO. In addition, that office will be responsible for reviewing the coding of professional fee services throughout the institution. With regard to the inpatient abstraction process that I just described to you, the Billing Compliance Office will be reviewing the work of each chart abstractor twice a year to make sure they are accurately and appropriately billing in accordance with all standards and all regulatory requirements. In addition, since abstraction under our program is only being done for inpatient, there will be an annual review of every physician's billing practices for their outpatient services. That annual review has basically 3 stages. Each year, there will be an appropriate sampling of each physician's charts that will be reviewed for billing compliance. The results of that review will be shared with the physician as well as their department chair. If a physician is not found to be in full compliance on that initial review, the physician will be required to undergo an expanded review, which involves a sampling of a larger number of charts. If after the expanded review there is a determination that the physician is in compliance, then they will be reviewed again in 90 days and receive some educational counseling. If a physician is found not to be in compliance after the expanded review, they will go into a process which we call concurrent review. Their outpatient charts will be abstracted, as I described the inpatient abstraction process, for a minimum of 30 days or a review of 100 charts, or longer until the physician is found to be in compliance for 10 days. After compliance for 10 days, a follow-up review will be done in 90 days. The costs of this outpatient chart abstraction will be borne by the physician personally, and it can be an expensive process, costing the physician up to $5,000 a month for the abstractors to do their charts. It is also essential that if in the course of the auditing process corrective action is deemed necessary, it will be promptly taken. A part of our compliance program that was added by the government is an external monitoring process. The CPUP, the clinical practices, will retain an independent auditing firm who will do a review of professional fee billings on a yearly basis and report the results to either the government or our intermediary for the next 5 years. The most difficult, but probably the most important part of any compliance program is mandatory education and training. This is the part where you must develop the standards to be followed in your institution, and then you must educate and train all those responsible for billing to make sure they comply with those standards. It is a very difficult and time-consuming process to develop these standards and educational materials. The standards must fully comply with all regulatory requirements, which may be changing very frequently, but they also must be standards that you in your institution can follow. As Steve said, standards that aren't followed are not part of an effective compliance program. We are in the process of developing an educational manual, which is what will disseminate our standards. The educational manual has to take into consideration the institution and the specific needs of a teaching institution and residency requirements. We have in our educational manual a specific section that deals with specific requirements for teaching institutions, which will now, as all of our standards will have to be updated and monitored to comply with the new regulations. We've also had added in our educational program a specialty-specific section which will help in educating each of the specialties as to how these rules apply to them individually. The education is mandatory. Attendance by all medical staff, fellows, residents, and billers is required once a year at a minimum with mandatory attendance requirements. If an individual fails to attend within the time period, and you do in developing your program have to make it reasonable, you have to give them enough opportunities that they continue to practice medicine and do their research and do their teaching and still spend the 3 or 4 hours it takes to attend an educational session. But if an individual fails to attend one of the educational sessions made available for them, they will be required to have an individual training session, and they will pay the cost of the trainer. If they do not attend one of the scheduled sessions and they do not, within the required time, have an individual training session, the physician's billing will be suspended until the training sessions are completed. The training sessions and the education are the key to a successful compliance program. The emphasis, as you heard today, of our educational program is the importance of accurate and complete documentation. Billing has to match what is documented in the chart, and that is the best way to avoid problems if the government seeks to look at your billing requirements. The fourth element in our compliance program is a government-required element, and that is dedicated information and reporting lines. The information line is a resource to all physicians and billers to answer billing questions before a bill is submitted. The reporting line permits the reporting of billing practices which anyone across the institution feels should be looked into by the CFO. The reporting line is a different number, and it is a confidential line. These elements are important parts of a compliance program. It's an element the government looks at, and it is important that the government see that these lines are not only in existence, but their existence are widely communicated. In summary, there are a few key points that you need to take away in understanding the importance of developing a compliance program for your institution. One, recognize that in developing a compliance program, sessions are difficult in an academic environment. Unlike a for-profit, it's not easy to just fire somebody if they don't follow the rules completely. We are living in a world of tenure and due process and academic freedom, and developing of appropriate sanctions in an academic environment are difficult. It is also absolutely essential that there be communication from the highest levels of administration of your institution regarding the importance of complying with legal and regulatory requirements. Any compliance program must clearly demonstrate that regulatory compliance is an institutional priority. As I indicated, take steps to communicate, educate, and train regarding your standards. You may develop great standards, but if they're not followed, you don't have an effective compliance program. You must have consistent enforcement and discipline when there is a failure to comply. This process assures compliance and again serves to emphasize the importance of compliance as an institutional priority. Once an issue is learned, respond promptly. If you detect an issue, respond to it. And as you heard this morning, the reality, whether we like it or not, is that if it isn't documented, it didn't happen. Thank you.
The Association of American Medical Colleges advises all members to implement the Medicare rule as quickly as possible and to develop internal compliance programs to assure accuracy of Medicare claims filed by teaching physicians. The AAMC also advises its members to determine whether their state Medicaid program has adopted the new Medicare billing rule, in which case the rule also would apply to services provided to Medicaid beneficiaries.